somatoform disorder is a main topic, but the problem is usually people then want to take this lecture because it's a very difficult topic, very vague and a difficult topic. And the problem, other problem is now this DSM-4 and DSM-5, two different classification and two different name. So for your exam, it's very difficult to say which classification is they are going to ask, and so that's a important thing. So I put it as a somatoform disorder. The modern classification, they are call it as somatoform somatic symptom disorder. So previous classification only you are call it as somatoform disorder. So it's actually soma mean body. So body we are giving lot of priorities, right? So soma means body. So these disorders with some obvious connection with the state of body. So people who are in the morning always brushing and washing their face and everything, why? The body. So rather than they are not talking, or they are not giving much importance to the mind. So somatic things are very important in the human life. The tendency to express and communicate psychological distress in the form of somatic symptoms for which they seek medical help. So I think this picture shows the importance of the soma. Why these people are using these things? I think most of the people you have this, no? Like putting this nool and other thing. But actually it's spiritual. It means it's in the mind. But symbolically it's in the body. So that's why you are doing this. Otherwise no point, no. Everything is in your mind. Spirituality. So somatic, what you call, is a metaphor or the schema. So most important problem in somatization is one of medicine's blind spot. Still people are discussing and talking in different terms of somatization. So the most common characteristic of the somatoform disorder is the appearance of physical symptoms or complaints for which they have no organic basis. So such dysfunctional symptoms tend to range from sensory to motor disability plus hypersensitivity to pain. So somatoform disorders are characterized by symptoms suggesting physical illness or injury, but which may not be fully explained by a general medical condition or another mental disorder, or by medication or substance side effects. Also, that is an important thing. So it's either medical condition or the mental illness, or due to medication or substance use. The symptoms are either very distressing or result in significant disruption of an individual's ability to function in daily life. So why we are talking, or why we are worrying about somatization or somatic symptoms is giving a lot of distress or dysfunction. So psychiatry, you have to think in terms of first it's distress, dysfunctional and disorder. The last one is disability. So depression, you can put it in 4 categories. Sometimes it's only a transient distress, depression. Sometimes with the severe, it's a little bit dysfunctional. Even though it's dysfunctional, it's subclinical. You can't diagnose as clinically as depression. If you can, then it's a disorder. If you are not treating the depression for a long time and leads to a lot of difficulties, then it's become disability. So it's so here main dysfunctional problem is there, function of the daily life. So giving some example of psychosomatic illness. So usually bronchial asthma, most of the bronchial asthma, they have a sort of genetic position and everything is there. But exacerbation of asthma may be due to psychological reason. Like ulcerative colitis, eczematous disorders, very driven. So these are the psychosomatic, the most common symptom, abdominal pain. Very good example. Most of the children presenting to OPD is abdominal pain. You know, some study shows 75% of the abdominal pain in middle childhood is this category. Usually when they are starting in the morning only, the children are getting somatic pain, abdominal pain. Why they are getting this abdominal pain? Fear of going school, new teacher, English teacher, lot of. So abdominal pain is a very common presenting symptom. Chest pain, dyspnea, shortness of breath, perumuchu, headache, and fatigue, plus cough, backache, nervousness is the common word people are using. Dizziness is also very common. So forms of somatization, usually medically unexplained symptoms. There are medically unexplained symptoms, so we are now giving to that as a somatization. Other one is the hypochondrial somatization. Thinking about the disorder, all the time I am having some illness, even though if you are reassuring, person is telling that I am having, why don't you do some investigation like that. Other one is somatic presentation of psychiatric disorder, depressive disorder. Usually after 40 years, if the person is a female and presenting with severe somatic disorder, you have to exclude depression first. So most common presentation in Sri Lanka is somatic symptoms. So somatic complaints, patients who experience their symptoms but do not deliberately produce them is somatoform disorder. They are not deliberately presenting. So patients who knowingly create symptoms in themselves, either for material gain, is malingering. You can see in the army people, they are coming with malingering. So recently I went to this Anuradhapura Army Hospital, lot of people are malingering. They are presenting with some PTSD symptoms, auditory hallucination. So for their material gain, they can get a retirement, early retirement or a early pension and other thing. Or for more subtle benefits, such as gratification of the parent role, factitious disorder. Like sometimes a mother is having a difficult child or hyperactive child. So mother wants to get some excuse and producing some symptoms. But there, some gratification is there, but there's no material gain, but some gratification. So there's a pathophysiological mechanism behind this. So physiological mechanisms are there. So having autonomic arousal symptom. So people coming with palpitation and saying I'm having palpitation. There, the physiological changes are there. But he is interpreting that physiological changes not as physiological changes, as a illness. So that is a problem, right? Sometimes muscle tension. Usually this neck stiffness, common problem when you are facing the exam, hyperventilation, Now for the scholarship exam also children are coming with hyperventilation. So some small vascular changes are there. Cerebral processing is there, problem in the cerebral information processing. Physiological effects of inactivity, sleep disturbance, all are physiological mechanism. So not only physiological mechanism, psychological mechanisms are there. Some perceptual factors are there. Sometimes they are perceiving that I am having some problem. You know, most of the time when you are getting palpitation, you are not perceiving that that is a problem. But sometimes you are perceiving whether I am having heart disease or something. And your beliefs are there. There are a lot of beliefs. Why? Recently one person died due to after a palpitation or sweating. Now when you are getting that, you are correlating that. So it's in your belief. Sometimes it depends on your mood. Especially your negative mood leads to this. So when you are in a happy mood, you are getting palpitation, you are not bothered. But when you are in sad mood, then the palpitation leads to a lot of interpretation. Personality factor. Some people, you know, you can see in your batch also, 10 to 15% of the people always fond of illness, saying headache, backache, all other aches. Sometimes in the faculty, to get some attention, they are showing some symptoms. To get a person's heart, you can show some symptoms. So some factors are very important. And other thing is interpersonal mechanism. Usually this somatization or somatoform disorders are reinforcement. Actually reinforcing action of the relatives and friends. Recently also we had a child of grade 4 having fainting attack and abdominal pain. The mother is also having the same thing, and whenever the boy gets this symptom, mother giving good attention and taking to the hospital and showing to the doctor and showing to the other people, and the grandma is also coming when you are getting the abdominal pain. And the healthcare system, when people are coming with small backache, you people, you are the one who make it big disaster now. So if they are coming with small backache, then you will say, oh, there may be maybe due to some cancer, right? So those healthcare system and the disability system, we have some compensation they are giving. In many, now the problem is people are coming with this disability form to get some money. They are coming with this symptom. Some are malingering, some are somatic. Recently, in the private sector, I had a patient. She came with. She said that I am depressed. I am severely depressed. I said, I don't think you are depressed. No, I am severely depressed. You know, a female. So then why? No, I am going to marry. Yes, marriage is going to lead to depression, but why? Now only you are marrying, no? It will, after 3 or 4 years only, the marriage will cause some depression. No, I am going to marry in Singapore. The person from Switzerland is coming there and I am going to marry. Then why? No. Now I am depressed because after the marriage I have to come back, no? Then I am going to be depressed. So why don't you give a letter saying that I am depressed now onwards, then I can claim or I can get the visa. So that is partly malingering. Partly somatization, you know, leaving appearance and going to marry. And marrying is distress. Marriage is a distress thing or a happy thing? Initially it's a distress thing, because organizing a marriage itself a distress. Then plus living with another person, very difficult. Superficially okay, hi, bye, it's okay. But when you are dealing in a deep emotion, it's very difficult. So marriage itself is a distress one. So when you see the prevalence of medically unexplained symptoms, it's a main common reason get help seeking in the medical profession. So people are coming with that. Especially, they did a study, they found 15 to 25% in the primary care. So primary care, 15 to 25%. In Sri Lanka, I think more than that in the primary care. And in OPD, I think 1/3 of the people are definitely coming with this, especially in Manny. I don't know about the Jaffna. So 39 to 52% in a specialist clinic, more than 60% in neurology. Neurology, that's why if you want to do a, female can do a neurology as a postgraduate studies because it's good. People are coming with most of the time medically unexplained symptoms. So usually there is a psychological problems or conflicts underlying, right? So psychological conflicts leads to this. Say in medical students, starting an affair, or somebody asks you, or somebody proposes you, then whether I can say yes or no, yes or no, yes or no for a long time leads to somatization. So there's a conflicts of interest, or conflicts, different conflicts, whether it is right or wrong, whether it is good or bad. So usually in A level, after the O level exam, people are developing this somatic symptom, right? Whether I can select maths or bio, maths or bio, so like that. So there are also personality is a very important factor. Some people wait most of the time. Some people are very good in decision making. Then usually this physical and laboratory examination not explaining the that complaint. Our people are very fond of this lab test, no? People are having files of lab tests. Last week I saw a person, UFR report of 10 years back, she underwent surgery, that time she took some UFR report, still keeping that report, UFR in the file. So don't keep your pregnancy test for a long time. Then the other important thing is morbid preoccupation. Usually we are having preoccupations, this morbid preoccupation, right? When you are seeing that, when there's a snake here, you feel anxious. It's reasonable. You have to. But when you are thinking, when I'm going out of this building, if the sky is fallen down, what will happen? Then it's a disorder. So anxiety symptom is not disorder, but anxiety can go into the disorder, disability and everything, right? So DSM-4 classification, somatoform disorder. A group of disorders that include medical symptoms or the medically unexplained symptoms and complaints for which an adequate medical explanation cannot be found. First thing, to come to it, not intentionally produced. Then it's malingering factitious. Onset, severity and duration of symptoms are strongly linked to psychological factors. So there in DSM-4 classification I have put both because now almost the DSM-5 is available. So people will ask DSM-5 classification also. In DSM-4 classification, somatoform disorder, somatization disorder is the first one, conversion disorder, hypochondriasis, body dysphoric disorder, somatoform pain disorder, and undifferentiated somatoform disorder. Somatoform disorder not otherwise specified. Usually not. These last two is always there in the DSM-4, all the categories. So other 5 other classification. DSM-5 is different because DSM-5 makes significant change to the diagnostic criteria from previous editions by from DSM-4 mainly talking about the unexplained symptom. If some medically unexplained, you can put it into the somatoform. classification, the on a person's thoughts, feelings and actions. Not only if somebody is having a medically unexplained symptom, you can diagnose as somatoform disorder. It's a crude method of diagnosis. But the impact, maybe a preoccupied or preoccupation of anxiety or something, feeling, all the times getting negative emotion secondary to the symptom. And the actions, the behavior, is not studying for exam. So that impact now considered as an important thing rather than unexplained symptom. So the new name is somatic symptom disorder and other related disorder. That's to give a good marks. Classification 2015. So they are there. Nearly 50%, 46%. Conversion disorder is 21%, but Sri Lanka conversion disorder is much higher than the Western. The somatoform pain disorder is 13%, hypochondriasis 7%. This is a Western, I think, Western study. Conversion disorder, especially, those in uterus. Hysteria, stress means uterus. So this is a very good diagram because all other disorders they are put it as a somatic symptom disorder. Hypochondriasis they put it as a illness anxiety disorder. So now the word hypochondriasis is not there in the classification. So you have to call it as a illness anxiety disorder. But other disorders like pain disorder, somatoform disorders, somatization disorder, other disorders, they are put it as a somatic symptom disorder. So somatic symptom and related disorder. So the diagnosis, new diagnostic criteria, a group of disorder characterized by thoughts, feelings or behaviors related to somatic symptom, not medically unexplained symptom, right? Second one is somatic symptom disorders and the other related disorders challenge medical providers because why we are giving lot of importance for this? Because people who are coming with the OPD, 1/3 of the people or maybe 40% of the people are having this disorder, then the health resource maximally utilized by these people, not by other important people. So that is a problem. So high utilization of the medical system and challenging patients population, chronic and difficult to treat, always is chronic, repetitive unnecessary diagnostic tests, usually they are coming and you are giving repeated tests, sometimes invasive medical, sometimes surgical intervention. You can see some of the people have undergoes several surgical intervention due to the symptom. And risk of medically induced iatrogenic illness, maybe due to this investigation and the intervention, people will develop iatrogenic illness. So that's why we are mainly this category is important. So somatic symptom and related disorder is the third highest psychiatric disorder. First depression, second anxiety, then the third. So prevalence is 8.9%. Usually with a female preponderance. Female, say, somatic, I think 10:1. Hypochondriasis or illness anxiety disorder 5:1. So the problem is begin at childhood and adolescence or early adulthood, usually starting. So new onset of unexplained somatic symptom disorder in old adult should prompt a search for called medical illness or evidence of associated major depression. So I said 45%, 45 years, after 45 years, if they are presenting, there may be a underlying medical problem or a psychiatric illness. But starting at early childhood, a person who is 35 years old, not married, right? Main diagnosis is somatic. Usually they will present with symptoms. You can come to a conclusion that is somatization. Right? After marriage you are getting headache, but before, if you are not married, you are getting somatization. So subtype, there are a lot of subtypes, several subtypes. So this is the new classification. So I have put old classification also because sometimes your examiner will ask about the old classification because, right? So somatic symptom disorder, right? Then illness anxiety disorder, hypochondriasis, conversion disorder, the hysteria, or now they can call functional neurological symptom disorder. The fourth one, psychological factors affecting other medical condition. The fifth one is factitious disorder. Clear? There are 5 under new subtypes. These illness anxiety disorder, most of the time your examiner will ask, then it's equal to hypochondriasis. Then the conversion disorder, same. Now there's no somatic pain disorder and somatization disorder, psychological factors affecting other medical condition. Fifth one is factitious disorder. Pin drop silent, why? Everything is understood. Good. So I have put this DSM-5 criteria for somatic symptom disorder because you have to know the criteria, then only you can diagnose. But fortunately, you don't have final year subject, no? Final year 5th subject, psychiatry, no? Huh? They have the no. Next batch only, next year only. You are only getting a final year in the medical medicine. You will get some question. That's all. Right. So then easy. So usually one or more somatic symptoms that are distressing or result in significant disruption of daily life. So 2 things, distressing and dysfunctional. Second, B, excessive thoughts, feelings, behaviors related to the somatic symptoms or associated health concern as manifested by at least one of the following. One is disproportionate and persistent thoughts about the seriousness of the one symptom. One day if you have a headache after doing some appointment, for a day sometimes you neglect, it's nothing. But sometimes you started to preoccupate, why I am getting this, especially when you are closer to the exam, when you are having an appointment, finally appointment, then you will get sort of focusing on this. Otherwise you have to focus on the exam, no? So you shifting the focus and started to preoccupy. And persistently high level of anxiety about the health of symptom. High level of anxiety is important. No, I am getting this headache now. Most probably I am not going to pass this exam because I am not able to do the exam properly. So your level of anxiety is high. The third one, excessive time and energy devoted to the symptoms of health concern. Otherwise, all the people are having somatic symptom now. But we are not bothered of that. We are not getting anxiety because of that. And we are not wasting time on that. Right? I think that is explainable. See, although any one of somatic symptom may not be continuously present, the state of being symptomatic is persistent more than 6 months. So transient symptoms are not that important. So duration, Chronicity is important. Duration is important. It's clear. After finishing the lecture, you have to develop some of the somatic symptoms, either backache, palpitation, or headache. Otherwise, lecture is not good. So make it simply. So somatic symptoms and ABC, chronicity and the excessive thoughts, feelings and behavior. So this is 3, right? And you can put it as a mild, moderate, severe, depends on the criteria. So only one of the B criteria fulfilled, then the mild. B, 1. Then 2 or more will be criteria, moderate. 2 or more B criteria fulfilled plus multiple somatic symptoms. Several symptoms, severe. You, at least our demos clear? One person is slowly nodding, then other person is smiling. Okay. So I don't want to put it into it's difficult because we have some 5-4 problem. Even in a PG is difficult thing nowadays. Even in a MD psychiatry, people are confusing now. So I don't attention seeking. So usually this hypochondriasis, this doctor shopping, lot of doctor shopping. Our people going because when you are not reassuring, she is going to another doctor. When you are reassuring, she is coming again and again. So it's very difficult, hypochondriasis. So I have put it in the ICD-10 diagnostic criteria. If you really want, you can copy it, because don't write it, because if you want only, you can do it. Other important thing is psychological factors affecting other medical condition, the 4th one. So the factors have influenced the course of the medical condition. Example, close temporal association between the psychological factors and the development or exacerbation of a or delayed recovery from a medical condition. Example, asthma. So your asthma, bronchial asthma, sometimes maintained by the psychological factor. Husband and wife argue, fighting, asthmatic attack, going to the hospital, ending the conflict. And another episode, we can see. So there's an association. Maybe the development, maybe the exacerbation, or delay in the recovery. So the factors interfere with the treatment of the medical condition, because of these factors, some factors, poor adherence, say psychological factors, whatever I do, I won't recover from this. Then people, they not adhere to the treatment. So that will lead to the illness worse. The factors constitute additional well-established health risks for the individual. Sometimes people started to do some investigation. Like some people, one of medical student from abroad came and saying about HIV testing. So all the time, frequently doing HIV testing and other things. So like that, lot of problems are there. So psychological factors are chronic occupational stress and hypertension. Now it's a well established. Lot of studies show that chronic occupational stress leads to hypertension. There are some physiological mechanisms for that. Cortisol level increase, and there are a lot of things. Anxiety and asthma, depression and coronary artery disease, well established one. Alcohol abuse and liver disease, that is more than something psychological, more than that. Smoking and COPD, obesity and diabetes. So other important thing is body dysmorphic disorder. I don't want to go into, because it's in the previous classification only it appeared. Preoccupation with an imagined defect and exaggerated distortion of a minimal or minor defect in the physical appearance. Some people going into the in front of the mirror and checking whether the nose is in a correct position or not. Some people are coming and taking X-rays whether the brain is there in the skull, right? So, usually this body dysmorphia disorder comorbid with major depression and psychotic disorder. Schizophrenic, I think 25% of the schizophrenic people who prodrome schizophrenia is having body dysmorphic symptoms. Right? Everything is thorough, no? Schizophrenia, depression, everything is. So, I don't want to, because they started to do something for the nose, and sometimes they are going to do some operations and going to the some places like doing some facial and other things, lot of things. Other one is factitious disorder. That is also important because here the individual presents himself or herself to others as ill, impaired or injured. The mother is, I'm having an injury, but actually she purposely created that injury to get some excuse from the doctor in look after the child. Right? Those days in the previous classification is Manchester syndrome is factitious disorder. So the deceptive behavior is evident even in the absence of obvious external rewards. But usually in malingering, you are getting external reward. When you are showing that my leg is limping or something, you will get some compensation from the authority. But here there is no big compensation or no reward, but at least giving some excuse or the gratification, right? So called by proxy consciousness. In the they and so hospital, why home the husband hit them, so he's putting blood into the urine and showing that she's still ill. So that is called proxy. So malingering I have put already. Somatoform pain disorder, predominantly pain. This I prepare for you people, because this is first time I have prepared a slides like this. I never prepared and doing lectures with this PowerPoint. It's I think least effective method of teaching in my opinion. Whiteboard and the marker is the effective way of teaching. So somatization and depression, there are a lot of evidence in studies, right? And pain also mainly. So principles of management. So are you now clear about this or confusing? Clear? It's difficult, no? Difficult to say. At least I started to cry, yeah? Too much of sympathy. So, first when they are coming with symptom, you have to acknowledge it. The child who develop abdominal pain when people want to go to the school, the symptoms is true. Maybe the origin is from mind and the symptoms is true. So you have to acknowledge the symptom. So you have to show some empathy and accepting that the pain is there. Because symptom is true. This is not malingering, no? So this is symptom is true. Sometimes you have to arrange a regular coming to the hospital will relieve some of the problem. Checking pressure on and off, checking eye on and off. So this perception leads disorder. So you have to treat the mood and anxiety disorder. If it is associated with depression, treat the depression. That's why sometimes we are giving SSRI antidepressant to this. But you have to be very careful. Minimize the polypharmacy and multiple diagnostic tests. Earning through this ulcers and buying land cars. So provide specific treatment when indicated, especially CBT. Sometimes CBT is a specific treatment, but sometimes, as what you call, some people said about placebo, doing some surgery or something, they will do some procedure or something, they will satisfy, right? So reassurance that nothing is wrong does not help. The patient does not want symptom relief, but rather a relationship and understanding. Yeah, the relationship is important. My doctor said that there's nothing. So that relationship is important. And your empathy towards the symptom and acknowledgement is very important. Little is to be gained by saying that it is all in your head. Don't say it is mental or all in your head. You should acknowledge the patient's plight, avoid challenging the patient. Don't challenge the patient. Right? A positive organic diagnosis will not cure the patient. Somatization may coexist with any physical illness and may initially mask the illness. That you have to be very careful. Anyhow, treatment and psychoeducation are important. Treatment, psychoeducation is very important. I said it's a mind-body relation. Mother, your functional level is very good. Say, that lady said, Maavadikira. So Maavadikira means, this Maavadikira means 90% functional. You have to be 90% functional. So it's more functional than you. So you can say that your mother, your functional level is very high. Right? So it's sometimes you are shifting the focus. Somebody is coming with and saying about knee pain every day, facing the life problem, you have to shift it. There's a final medical student coming with headache, closer to the exam. So always coming, I'm having severe headache, otherwise like that, So on your headache, this is very important. Take some Panadol but management, not a psychoeducation. Anyhow, this mainly is cognitive distortion. So CBT obviously, but this is drug treatment. Of course, SSRI and tricyclic antidepressant you can give depression or anxiety. So when there's a problem, trauma is very important. Massive trauma. Another important thing is they don't trauma. That's why that's in our practice. Everything you. So if you started a fear, you won't. Enough. Enough. So difficult topic. I try to do it in a not a nasty manner, it's a good manner. So simply this all theory, but if you understand, some people with somatic symptoms are getting recognition, right? So you are brushing and you are washing the face regularly, no? For your mind, but what did you do in the morning today? And especially in an International Yoga Day, What did he? Nothing. Praying? Do you, huh? Did you go into the Swami room today? No. Huh? Church? So, obviously body getting the recognition. And our language is mainly body language. If I in the morning, if I say to my wife, darling, I have some mind, can I take leave and can I take rest? Then Nikita, take rest something, then she will not attending. But if you say, see, me, I have some neck pain, I am very difficult to turn the head, then wife will come with a Siddhalabe and put it into my neck. So it's a body language is respecting and they are giving acknowledgement or attention. So people, we all have body language. Our communication also, non-verbal communication is 60 to 70%. When you are coming home after work, you can, after seeing your partner, you can come to a conclusion whether today is war or not war. No war. So it's not, it's simply. So somatic symptoms are always there from the human. Right? Earlier, people were started to seeing everything as a holistic one. But this dualism leads to a lot of problem. Here, even this speciality now in our field, the speciality leads to a lot of problem because most of the doctors all the time palming off it to the another speciality. That man is going here and there and coming ultimately to the psychiatric clinic. We are helpless. Right. So you can do some intervention to minimize the functional defect or dysfunctional level and to realize the patient or person with having this symptom and always sort of telling this symptom, no use. Because if you started to say headache, the examiner will consider that in the final exam. This girl is having headache, oh, that's why he's not well or something. He's not going to accept. So rather than putting it to your head, why don't you study? And anyhow, the deadline is there. They are not going to change the deadline. So you have a limited time. So intervention is psychological intervention, but CBT is a different technique, but it's very huge one. I can discuss for half a day.